Use the word micturition.
How do you know that?
You should know what that word is. We only talked about it 20 times the other day.
I already forgot.
It's the scientific word for the act of urinating.
Urinating.
Micturition. All right, so we're going to start talking about the actual procedures, guys. Now, when we're setting up these exams, we're going to use various equipment depending on the type of procedure that we're going to be doing when it comes to urography exams. Sometimes they'll be intraoperative, sometimes they'll be in a fluoro room, sometimes they'll be a combination of the two. We're going to look at retrograde studies, we're going to look at IVUs, we're going to look at cystograms, we're going to look at cystourethropgrams as well. So many of the units will be a combination cystoscopic and radiographic unit. In other words, urology is going to be heavily involved with these as well. They have the cystographic equipment while you provide the radiographic unit, usually in the form of a C-arm. If we're going to be doing a combination surgical type cystogram. So that's going to be needed for our retrograde urographic procedures. And retrograde urographic procedures basically means that they're going to catheterize the patient all the way up to the ureters, inject contrast directly into the kidneys, and try to check the function of how it's working. Thus why it's often done in surgery. It's a more invasive type procedure. Now back in the day, we used to use what was called a tomography unit. Anyone ever heard of a tomography unit? Any techs ever talked about tomography? Very old machine that they don't use anymore. Basically, it's the precursor to CT. It would be an X-ray tube that would take periodic slices of a patient, and they look really ugly like this right here. That's a tomogram. We don't do those anymore, but in some rare cases, if they're going to do what's called a nephrourogram, they may use some of these old units if they have them available. But most often, they're just going to go to CT because most hospitals have sold these. They don't have them anymore. So CT's kind of taken over the kidney type exams, just like it's kind of taken over everything. Moving on, we're going to use time interval and body position markers. Are these going to be digital or physical? Physical only, even though your hospitals probably are hiding those in a cabinet somewhere. They do have time markers. Believe me, they do. We're going to use our sufficient number of proper size image receptors. Make sure our emergency cart is available as well in case something goes wrong with the patient. Know the location, know the supplies, also know where your venipuncture supplies are. We're going to talk a lot about IVUs here today, even though most of the hospitals that you're rotating, well, I don't think any of the hospitals you rotate through actually do IVUs anymore. IVUs are intravenous urograms where they would inject contrast into your arm, and that contrast will flow into your kidneys and you go through the normal process, antegrade fashion like we talked about last time. But some facilities you will still see these IVUs. They're just becoming more and more rare as CT's kind of taken over all of the kidney type exams more and more as the technology advances. But we still got to know them for our registry. So for the procedures, we're going to go over image quality, motion control, ureteral compression, which is exactly what it sounds like. We're going to compress the ureters, respiration, preliminary exams, and radiation protection, as we should always be doing. Image quality. So contrast for your urogram procedures are going to be the same as abdominal radiographs. Why? We're doing KUBs basically for all these exams, which is nice because that's easy to remember. Soft tissues that must be defined. We need that sharp outline of the kidneys, which we do see right here. We want the lower bore of the liver, and we want the lateral margins of those psoas muscles. Those three things confirm that we're doing a properly exposed abdominal radiograph, especially for our urograms. Bone detail will vary, as you guys know by now being seniors. It will detail according to the thickness of the abdomen. I'm sure you've had to x-ray some very thick abdomens. And you've seen how that image quality will suffer greatly depending on how thick the patient is. Definitely will vary quite extreme. Motion control. So motion control is always going to be something we're combating. By the way, guys, and you should have had this question in Mr. Fung's class. If you haven't, we'll give it to you anyway. What is the main mitigation factor for patient motion?
Breathing controls?
No.
Decreased exposure time.
It was right there, guys. Exposure time. Exposure time. A long or short exposure time? Short. That's still the number one way to eliminate patient motion per your curriculum, guys. Please do not forget that fact. You're going to see that a lot in my class next semester, that exact question in different forms. The main mitigation factor for motion is always exposure time, but also patient cooperation and breathing techniques. Now guys, please, as always, explain the procedure to your patient. Make sure they know what's happening, especially if they're going to get catheterized. You don't want them sitting up there thinking they're just up there for regular x-ray and then they're catheterizing them all of a sudden without any warning. You wouldn't want that happening to you either. Just like the bare minimas, explain what's happening, make sure you're comforting the patient, That way you have their total cooperation to help you along through that procedure. Prepare for any transitory distress caused by injection. Make sure you explain to the patient they can have reactions, is what that's referring to. Contrast does cause reactions to a lot of patients, things like flushing, hives, metallic taste in the mouth. You want to warn them ahead of time that these things can happen. That way they don't panic during the procedure if it does happen. I've seen it over and over again where techs just don't care. They don't explain anything. Also, this contrast is flowing, patients feeling flush and hot, they feel metal taste in their mouth, and they start freaking out. They have to stop the procedure, delaying everything and messing up the quality of those images. So explain thoroughly what's going on, despite what you may see out there. Make sure you prepare them accordingly. So in some of these procedures, we have to do what's called ureteral compression. That's exactly what it sounds like. You're going to add a compression to the ureters themselves, usually in the form of a strap going across the abdomen right here. So in excretory urography, which means that we're excreting urine, we're urinating usually on the table for these exams to check how things are flowing and looking for reflux. We're going to apply this compression on the distal ends of the ureters to help aid in slowing down the flow. Because actually, over here, Melanie, who's fallen asleep on me, mentioned that some people pee very fast. Which is true. Sometimes they pee so fast, we can't get those pictures fast enough. We need to slow that flow down a little bit. Slow it down so we get a good, pretty picture. Yeah, slow the flow. Slow the flow, that's right. So, that's the main purpose of compression. And yes, this is a scientific term, guys. Although we're not supposed to say this anymore. We retard the flow of opacified urine in the bladder. What does retard mean? It means slow. Slow. We retard the flow. I know it sounds funny to say that, but that's an actual scientific term. And the reason we do that, once again, is when those people they urinate too fast or too strongly. So we want to slow that flow down so we get a good analysis, and we can check for that reflux back into the kidneys. Now the compression goes over a very specific spot. It's going to be centered over the ASIS. That's at the level of your ureters, over the ASIS. It literally is just a belt that compresses on the abdomen. Now it helps slow down that urine flow just a little bit. It slows it down. It slows it down. As it's supposed to.
You actually seen? You actually seen the use of that?
The compression a couple times.
I would think it would
At least where I worked, they actually didn't use the belt. They would use that balloon and push on the baby's abdomen. Like they do for the small bowels, things like that. Okay, so when you do your ureteral compression, you want to apply it and remove it slowly. Why? Because if you imagine if you have something compressed, like think of like a water hose that you compress and you release it really fast, the water shoots out. You can do that same thing to the patient if you remove that belt too fast. It'll start flowing really fast. It can actually be very painful to the patient. So you want to remove that very slowly to allow it to flow back to its normal volume. Contraindications for ureteral compression are going to be urinary stones. What's the actual word for kidney stones? You're thinking of gallstones.
Renal calcus.
That's colips.
Your word.
Renal calculi. Renal calculi. I'm glad y'all, well, at least you remembered one word. It was the wrong word, but hey, it's something.
See, I had that same problem earlier.
Yeah. Abdominal masses, aortic aneurysms, colostomy bags. Please don't put a compression over a colostomy bag. You're going to have a big mess on your hands. Huh? Yeah, it's going to smell, yeah. Coke brown.
It's gonna be a coat.
Is it true that people kind of smell?
They do.
They do?
Most people don't clean around there properly, so it gets infected and kind of gross. They'll take that bag off, and that's a pungent odor. Hits you right in the nose. Suprapubic catheters, traumatic injuries, and any recent abdominal surgery, you could actually tear the stitches using that ureteral compression. I don't like colostomy bags. They gross me out. Yeah.
Can they pop out?
Can they pop out?
How does that work? Like when they put that?
It's latched on there.
Yeah. But they could pop out or no? They come off?
I suppose it could. I hope not.
What is it called whenever they have a piece of it hanging out?
That's a stoma.
Oh, is that what it
Piece of the intestine. It's usually with the bags around.
It looks nasty.
I've seen them put
It's even more nasty when you watch them defecate through it.
I thought it was something else.
Or like you're doing a,
I've seen them put contrast
you
to it.
sometimes will do, you'll sometimes do VEs through the stoma, and that can be pretty gross too.
And release the bag so the contrast flows in. It's like
Okay, so respiration, guys. For all of our
Check
positions
out the back.
in this chapter, let's get focused back here, guys. All our exposures are going to be made at the end of expiration because we're essentially doing a lot of KUBs. A lot of KUBs. Everything's in the abdominal area, therefore we always shoot at the end of expiration. Now, because of kidney excursion during respiration, it's possible to differentiate the kidneys from other shadows by making an exposure on different phases of respiration. That's just getting really complicated there. Don't really have to worry about that. Image should be marked if exposed on phase of respiration other than expiration, but 9 times out of 10 you're going to stick with the expiratory method. Expiration only. It's going to give you the superior images.
And they have physical markers for expiration.
They're supposed to. They are supposed to. They just have them thrown in a cabinet somewhere, I guarantee you.
Keyword,
Supposed to.
supposed.
All right, so
Notice the
abdominal
count.
images are made before our urinary tract studies. We call those scalp images again. What's the purpose of scalp images?
To see what it looks,
see where you're
to see
at.
where it
See where you're at, check for prep, check for eating. It's going to obscure the image. Correct. We always do scalps before we do fluoro exams.
I have a
That's-
tech who would do a scout, like on the C-spine, to make sure they're just centered.
Seriously?
I'm not telling you where or who. But yeah.
They scouted the C-spine?
They would like position it and then scout it and be like, okay, you come down.
I'm going to keep my mouth shut what I want to say about that, but I don't like it.
y'all be sending us to these places.
That,
like
that almost
that.
gave, that almost need a moment. I need a snicker after that, yeah.
You should
Scout,
get us some.
it wasn't one of my former students, was it?
I'm not telling you. Oh, it was.
No, I'm not telling you.
I'm grabbing a sneaker.
What's her location?
I don't want to know.
Are you choosing right, Mr. Donahue?
Wait, you're an
No.
EC, aren't you?
I'll say it this way.
No.
You can lead a horse to water, but you can't make him drink.
Mhm.
That's all I gotta say about that.
It's
Okay,
like
scalp
Kool-Aid
APs.
on
Scalp APs, guys. What's that gonna show? The location of your kidneys, their contour, their shape, any opaque calculi. If we see calculi, it's a big contraindication for a lot of these exams. So we wanna look for those when we do our scalp images. All right, so it's also gonna check the GI tract for preparation and exposure factors, because they do have prep related to these urinary exams. So also checking that that prep was properly completed for those patients. All right, so radiation protection, guys. So of course we can still put our shield on the gonads for males, not so much for females because it's actually going to obscure the bladder. So males kind of get the special treatment here. They're the only ones that are going to get rad protection on these type of exams. Sorry to disappoint. But close collimation otherwise should be used. Avoid your repeat exposures and use that shielding in accordance to your state regulations. You guys know this all by now. If you don't know this by now, don't worry, you can come back to the junior class. We got a spot for you.
Dang.
No, you don't.
We got a couple of open seats.
No, thank you. You got 2 seats.
2 seats.
I wanted first.
That'll be a no for me.
Okay, guys, contraindications to compressing during excretory urography includes what? One and two. One and two.
1 and 2.
Hypertension would not apply.
Oh, wait.
So what's super pubic?
Sorry?
What's number 1, sir?
That's a special catheter that's near the bladder, like in the pelvic area, suprapubic catheter. All right, so these are the exams we'll be going over with their related positions. So much like with GIs that we talked about last chapter, guys, barium enemas, most of this is done just with fluoro. If you've seen these in clinic, they just do the fluoro images. Some clinics still ask for plain films, so we're still going to talk about the plain films and the related positions just like we did with the last chapter. But there's not near as many in this chapter as we just went through with the GI and lower intestines. So a little easier to remember these. So we'll be going over IVUs, retrograde urograms. Have y'all seen any of these retrograde
I did.
urograms?
That was the one I just told you about.
That is the one you-
Retrograde.
That is the one you told me about. It wasn't in surgery though, right?
No, it's in.
It should have been in
neuro.
surgery. Usually these are done in surgery. Retrograde urograms. Yeah, how can I forget that story? Cystograms and our cystourethograms, which you'll see, they are divided to male versus female. We do both of those a little bit differently because of anatomical differences, but we'll get to that. Oh wait, look at that bladder. That's a very messed up bladder right there. All right, so intravenous urograms, they can be shortened to the initials IVU. Back in the day when I was a younger x-ray tech, they called them IVPs. IVPs. The IVU is the most common used term these days, intravenous urography, also called excretory urography. And keyword for this one is intravenous. So how are we administering contrast? Through the veins. So it's going to go directly into the kidneys, flow down the ureters, fill up the bladder, and then they urinate as normal. It's an antegrade exam. We're doing the normal process of flow. Why do we do it? To demonstrate structure and function of kidneys primarily. This is a kidney-focused exam. We determine the function of the kidneys to filter that contrast medium from the blood and concentrate it with the urine. Primary application to evaluate suspected or continued presence of ureteral obstruction. So if the ureters are obstructed in any way, we're going to see that contrast stop, and that's a major problem, or slow down. That's a major problem that they can go in there and surgically fix for that patient. We can use a stent, we can use other methods to open up that ureter to help the flow go a lot easier. Very uncomfortable for people. That's what age will do to you. Sorry to tell you. I haven't had those issues yet, but you know, I'm staying away from those sodas. Trying to drink more water.
What's up?
All right, so what's our indications for an IVU? Why would we want to do this? Ureteral obstruction being the biggest and the most well known. Recurrent urolithiasis, that's going to be stones of the urinary tract or the kidneys. Congenital abnormalities like deformities of the kidneys, deformities of the ureters, deformities of the bladder, kind of like we talked about last class. Evaluation to investigate abnormalities that increase infection risks, because do remember the urinary system is very highly susceptible to infections, especially with catheterization. Assessment of upper urinary tract lesions that may explain hematuria, blood in urine by the way. Assessment of the effects of trauma and therapeutic interventions as well. So if they've had trauma to their back, trauma to their abdomen, and they suspect that the kidneys and ureters may have been affected, they'll do these IVUs to check the integrity of that system. But yeah, they don't do these at Harris Health anymore. They don't do them hardly anywhere anymore. Y'all know why? What do I keep saying is taking over everything? CT. They just go to CT. CT has those power injectors to the veins. They can fill up those kidneys really quick, get a much quicker analysis at the expense of frying and barbecuing your patient. But we like our patients extra crispy, right? So let's do. Yes, question?
When it says recurrent urolithiasis, it's like they've had the kidney stones, they've had them,
Correct.
and then they keep getting
going
them.
back. Correct.
Ben at the CT at Smith, he showed me, he pulled out these papers that were for the CT machines there, and he was showing me like the dose you get in relation to like getting a chest X-ray.
Mm-hmm.
And if like you were to get like a normal CT abdomen, like the dose is like, I think it's like 10 millisieverts or something, or it's MSV, I don't know. And but the like comparing to that, the equivalent effective dose for the number of chest rays you would get, you have to get 500 chest X-rays.
For one abdominal
For
CT.
one CT.
Wow.
It's absolutely insane how much dose you get. And
That's like 3 years.
it
of like
blows my
natural
mind
radiation.
how these doctors are so reliant on these CT machines. I mean, I'm sure y'all all heard, oh, send them a CT, but it gets them a lot of money. You ever had CT done and you get your bill in the mail, you about pass out.
$10,000.
At least.
So, okay, so if the doctor was like trying to really prevent patient dose, would be like, okay, can we just send them to MRI?
Well, they're not going to do urinary exams
For
in
MRI.
MRI. Just depends on what's being done. But MRI is no less expensive, I'll tell you that. And you know, who knows what we're going to find out 20 years from now. MRI might be affecting our cells in some way too. We don't know that yet. It's a newer technology. It's young. And right now we say there's no effect of magnetism on our cells, but 20 years from now, we don't know. It may be scrambling our DNA as well, for all we know. They think they even have some studies saying that there's some harm that comes from ultrasounds, like that they're seeing with people's cells due to the sound waves. I was seeing some scientific articles on that they're claiming there actually is harm done to cells with ultrasound. So you never know.
So would it be for like the patient or the technology?
For the patient.
Oh, okay.
Like it's like scrambling their cells with the sound waves.
With the vibrations.
With the vibrations.
Mom's got a question.
All right,
Bad
risk
bad
factors. What's going to be a risk factor for urograms? Things like asthma, previous contrast reactions, which is why we stick to our, what kind of contrast? Non-ionic. Circulatory or cardiovascular diseases, elevated creatinine levels. Should we do these exams with elevated creatinine levels? Why? Why is that a bad thing?
You may damage the kidneys even more.
You're going to send them to dialysis. Exactly. It may damage the kidneys. Sickle cell disease, diabetes mellitus, and multiple myeloma, all risk factors for doing these exams. Usually you're going to send them somewhere else and do something alternative.
What's mellitus?
What's mellitus? It's a type of diabetes.
Oh.
Diabetes mellitus.
Isn't that like type 1 or type 2? Don't they have names?
It's one of those.
I
I'm
forget,
not
I
a
get
diabetes
confused,
expert,
but-
so. Okay, so contraindications most commonly relate to that ability of the kidneys to filter contrast medium from the blood, and of course previous allergies. We always want to check that chart to see if they've had contrast reactions, because you would not believe how many people overlook that in people's charts. So you always want to be thorough and make sure you're taking a look at that. Some of these contraindications, of course, as we just mentioned, you can overcome those by making sure you're using non-ionic contrasts, which is what you should primarily be using anyway. Most of your facilities have only non-ionic anyway. High-risk patients may be evaluated with other modalities, if need be, but this is going to be your gold standard for your urograms. Although CT argues against that, though. Doctors argue against that with all the CTs they order. I really disagree with that, by the way, how many CTs they order on these patients. That used to bug me so much when I worked at TCH. Like, you just enjoy barbecuing these babies all day. You get so much money out of their insurance. And for like paper cuts, they're sending them to CT. Like, you people are sick. I won't go on a whole tangent when I keep talking about that, but
I am nervous to get to the pediatric chapters. Because you're going to be, and remember when I saw this? I saw this a lot.
I go ham on the pediatric chapter, yeah. It's interesting stuff, though. Y'all are ready for it now. You've been in X-ray long enough. You're ready for the crazy stories. All right, so before procedures, patients must prep in this way, emptying the bladder. We don't want them to have urine in the bladder. Remove all their clothing, bra, underwear, everything. And please put a gown on. Don't put them up on the table naked. They're already going to be exposed anyway. Do them a favor, give them 2 gowns.
Someone like it.
Some like it, I'm sure they do. Review the clinical history, allergic history, and blood creatinine levels. Some of them really do, yeah. It's actually not incorrect.
I had a patient yesterday in Memo. She walked in and she took them things off. She said, y'all gonna see it anyway?
She took them things off.
Her gown.
Some people just don't care. Okay, so GFR, big star on this, guys. That's our best overall indicator of kidney function, the GFR, glomerular filtration rate. Our normal GFR, you do need to know these numbers right here, guys. 90 to 120 milliliters. 90 milliliters minimum or less is going to indicate renal dysfunction. If we see anything on their charts indicating that number being 90 and less, please do not give them the go ahead to do that procedure. And that does happen. People overlook this stuff. You need to make sure you're checking that before you get them started on that procedure. Normal creatinine levels, another thing we check. 0.5 to 1.2 milligrams over 100 milliliters. Another very important level to make sure you memorize. It's one of those patient care questions that your registry likes to sneak on you. And I hate when they put those in there. Because I'm not a numbers person, that's the stuff I always forgot. I always write those down before I took my exams on my scratch paper. What'd you say?
It was 0, the normal creatinine? Yeah, it was 1 point something.
0.5 to 1.2.
On Radtech look at.
Something else, I thought it was 0.5 to 1.5.
You're going to see some slight discrepancies on those of what they consider normal. For this chapter, we're going to go with this level right here.
What's the
For checking urine. For checking kidneys, I'm sorry.
Oh.
And this is from
But the creatinine was 0.7.
And we're gonna get to that next semester. I won't tell you guys about the discrepancies you will find on lab values, because things like breathing rate, pulse rate, all that stuff does have slight variances between texts, but we're gonna go back and review that. For this chapter, I want you to focus on this one right here. Oh, whoa, hello. This one right here for this chapter, guys. Yes,
This is Bontrager?
this is Merrill's.
Okay.
All right, so IVUs, we're gonna make a scalp radiograph. We are gonna perform a venipuncture. Have you guys been improving in your venipuncture skills? Anybody? Or did y'all do it once and just run away from it?
No,
We
I
only
missed
been
my
there
countdown
once.
leave. Did you remember that? And I never
Well,
learned,
you're
so-
in luck. We got a beautiful brand new venipuncture arm that just came in the mail.
Y'all have another Leroy?
What are we naming this one?
Tyrone's been
Yeah,
retired.
Tyrone, that's what it was.
Tyrone, you know, he had so many drugs, so much heroin.
He
He,
yeah.
He was leaking
He blew all
everywhere.
his
He,
veins. Yeah.
He found himself an early grave. He's been put out to pasture, so
So
to
what's the
speak.
new person's
Should have
name?
kept it for Halloween decoration.
Tyrone's.
That would be a good Halloween decoration. It looks really real. Okay, so
Blood spout now.
important number, guys, for contrast amount for IVUs. We're going to use not 300, 30 to 100 milliliters for an adult patient. When you have infants and children, we're going to adjust that according to their age and weight. That's the same principle we use for CT, by the way. You have a normal stated amount that you use on CTs for adults. You're going to alter it for infants and children based on their age and weight. There's a little formula you use. We will produce radiographs at specified time intervals because the kidneys will fill up at different times. We'll go over those time intervals here coming up. So kind of like a small bowel, we're going to take periodic x-rays, watching those kidneys fill up, watching it drain down the ureters, and ultimately fill up the bladder before we let the patient go use the restroom and do a post-void. All right, so the most common radiographs for IVUs are going to be our APs at time intervals ranging from 3 to 20 minutes. And it's kind of left up to the tech on what time intervals you do. I've seen most people do like 3, 5, 10, 15, 20. At least when I used to do them, that's what we used to always do. That is kind of left up to the tech's discretion, but it's often going to range from 3 to 20 minutes. We'll do AP oblique projections, and please write that down and remember that, because people always want to put 45. We're going to specifically do 30-degree posterior oblique x-rays. 30-degree posterior obliques, so LPO, RPO. And we do those at the 5 to 10 minute intervals, because that's most often whenever the kidneys and ureters are completely filled up for those exams as they're draining down to the bladder. So unless we need bladder or voiding urethrograms, the patient will then be sent to the restroom to void. Void does mean urination again. Micturition, void, urination, they all mean the same thing. After that, we'll take a post-void of the bladder. We're going to be checking for tumor masses in large prostates, but also we're going to look for reflux to see if any of that contrasts reflux back into the ureters towards the kidneys. If we see reflux, that's a big problem that we need to make sure we investigate, get that patient some help. After the procedure, the patient will be instructed to drink extra fluids to help flush the rest of that contrast out of their system. So drink lots of water after these procedures. Flush all that residual contrast out of the system. All right, that's what they look like right there. It'd be a 6-minute film, 9-minute film, and a post-void right here. So we're gonna go from 5 to 20 minutes. Ultimately, we wanna see the minor and major calyces. We wanna see that renal pelvis. We wanna see that ureter filled with contrast, and we want, of course, to see that bladder completely filled as well. When we do a post-void, often you'll see some residual contrast in there just like that. That's normal. We expect to see that. What we don't wanna see though is a bunch of contrast still remaining, and we don't want to see it going all the way back up those ureters. That would be reflux. So we have a tiny reflux right here that you can see if you look closely. This should not be in here. So this person has a little reflux going on
On the left side?
on the left side, right here. All right, so here we go. We're gonna go through the actual positions. So AP urinary system, AP IVU. Supine, you can do it standing to demonstrate opacified bladders and kidney mobility, but most often we're just going to go ahead and do these supine. Support the knees because their back's probably already hurting because they're having kidney issues. Give a little support. And if you need to do so, you're gonna do that ureteral compression at this time to slow down that flow if it's filling up too fast, or if they have a history of filling up too fast. Heart position will be just like a KUB, guys. Center at the iliac crest. Breathing technique is taken on expiration. 14x17 cassette, lengthwise. Everything is done exactly like a KUB for this exam. Only thing that's different is that we're injecting contrast in the veins. So that should be a very easy one to remember there, guys. If you don't know KUBs by now, once again, we'll bring you to the junior class. Come move backwards a year. We'll find a spot for you.
Better give them people that's in the wait list.
The upright is only to look at the bladder and the kidney.
To look for a opacified bladder specifically, and to see if there's kidney, when it says mobility, to see if the kidneys are drooping. Looking for kidney mobility, to see if they're shifting. Now, if you do have a very tall patient, of course, using critical thinking skills, you can do an upper and a lower, just like you do for other things. If you're a really, really tall, skinny person, their kidneys will be way high up. You'll be missing the bladder. So you can do like your upper bladder shot, splicing together. All right, so like we said, guys, already, just like a KUB, IR at the level of the iliac crest, 14x17 lengthwise. Pretty standard. This is why I don't like giving you all my PowerPoints. You all just hang out on your cell phones while I'm talking to you.
I'm recording your voice. What are you talking about?
I never take notes.
That's why I don't like giving PowerPoints out. I know you don't ever take notes.
For those of us that are reading the PowerPoint along with you, we appreciate it.
All
And
right.
then look, I have the official book. Look at this, Mr. Dan. Come on, Mr.
But I wasn't on my phone. I was really just on my phone.
All right, so what are we looking at here, guys? Kidneys, ureters, bladder, thus KUB. That's why it's called a KUB, kidneys, ureters, bladder. So what do we want to see? The entire renal outlines, which we do see here. Beautiful. Bladder and pubic symphysis, indicating that we have centered properly at the iliac crest. Contrast view in the renal area, ureters and bladder. So we want to see those minor and major calyces, renal pelvis, ureters on both sides, and of course the bladder filling up with contrast. And yeah, that's our main things to see on that exam. The main things I have in red. That's what I want you to focus on for that. The rest of that stuff is not near as important.
You said the minor calyces is the.
It's the little tiny parts. So
It's the tree branches.
minor calyces, they converge to a major calyx, renal pelvis right here. Minor, major pelvis. Minor, major pelvis.
Did you make a hotspot?
Hmm?
Did you make a hotspot?
I think I have one from last year. I'm just gonna reactivate for you guys, yeah. Yeah.
So is there supposed to be a timestamp on this one?
There should be, there's not one though. Nope. Ad
Got it.
tech.
It says time marker on the
Sure does.
evaluation.
Okay, evaluation criteria,
It's on that
time
one.
marker.
It's on that one.
Time marker. PA projection, if needed, for lower kidneys and entire ureters. Superimposing intestinal gas. AP bladder, we would do an AP bladder shot for our tall patients if we don't see the bladder. Like if we go back, let's say I have a really tall patient and all I see is the kidneys and ureters and I'm cutting this off, I'm gonna opt for an AP bladder shot to get the rest of it on there. So if we do an AP bladder shot, of course we want to see bladder, prostate area in the male patients, and our labeled post-void images showing residual contrast medium as needed. Because your post-voids will often just be a AP bladder shot. We're not interested in the kidneys anymore. We're only looking at the inferior bottom area of the patient at that point.
So this is only if you don't get the.
If you don't get it all in one, or if you're doing a post-void.
You can't really see the next one? You said something.
You can't really see it well, but if you do, you're gonna see just a little bit of a, almost like a little pacified area right there. with the erythrophilic contrast. They say you're going to see it, but you don't really see it. It's, I don't know what they're smoking saying that, but they're claiming you see it. We can take a break. Yes, we can take a break. Please take a break. Come back at